of my favorite topics. And to me, I am a surgeon, but there's something very appealing about this ablation therapy for pancreatic cancer. And we do use ablation in a lot of other parts of the body too, but it's appealing to be able to have another weapon against pancreatic cancer in particular. And I think one could have very easily also called this talk something like blasting pancreatic cancer. I mean, who doesn't want to blast pancreatic cancer? Or, as we'll see later on, a very appropriate name would also be zapping pancreatic cancer. Just so we're all on the same page, ablation is our fancy medical term. Essentially just means destruction of diseased tissue, whether it's cancer tissue or not. We're destroying it. Sometimes we remove the tumor, we remove what it is that we've destroyed. Sometimes we leave it right where it is, and we let the body clean it up, just like an old bruise or like an old the immune system comes in and cleans it right up. And in the past, and this is dating back close to 50 years now, there's been various types of ablation used elsewhere in the body other than the pancreas. You'll actually notice most of the ablation that's been done in the body has either been on the skin or in the liver. And on the left of the screen, you'll see for a long time now, again, close to 50 years, alcohol has been injected into some tumors in the liver. And it makes sense that that works pretty well. It's a little uncontrolled, though, as to how much gets in there and all that. Something that came along, probably 3 decades ago, was cryoablation. So ablation, destruction of tumors in the liver, again, using freezing. And I guess what we see here are these tubes. Usually they'd put liquid nitrogen down and then it would freeze a ball of tissue. Sometimes that ball of tissue would just come with the probe when you tried to take it out. Sometimes we just sneak that out and leave it right in its place. And then over just the last 20 years, using heat in a much more specific, much more controlled way to cook liver tumors. It's not so much burning them as just getting them up to a temperature where the cells die, where the cells are cooked. And these are technologies, very good. We've been using them for a long time now at our center and elsewhere in Canada, known as radio frequency ablation and microwave ablation. And of course, here's a character who needs no introduction. It's the pancreas. And as surgeons, we have this real love-hate thing with the pancreas. I mean, we became pancreatic surgeons because there's something about it that appeals, that we're operating on the pancreas. But on the other hand, we really, really, really hate the pancreas. And I put turkey on the screen. That's just one of the names we have for the pancreas. That's probably the most polite of all the names we have for the pancreas. But again, a real love-hate relationship. And not to spend too much time on this, just to review the pancreas. And he's outlined in yellow here. I don't know if you can see the mouse pointer on your screens or not, but in yellow.
Dr. Mosier, so sorry to interrupt you again. The screen is frozen. It doesn't seem to be showing.
Oh.
We're still on the first slide here.
Oh no. Okay.
I don't know.
Okay, I'm just going to stop sharing.
Okay.
Again here. Okay.
Oh, there we go. That looks like it might.
Okay.
Yeah, there we go. Now we're seeing it change.
Oh, okay.
Great. Thank you so much. Sorry about that.
So yeah, I guess nobody saw the slide where we talked about the other types of tumor destruction, whether alcohol, freezing, or heat with radio frequency or microwave ablation. And then again, our slide where we're meeting the pancreas. And just as a brief introduction, I think probably everybody who's present here today has probably looked up the pancreas at some point. But the pancreas has 2 very different jobs. One of them is to make digestive enzymes. And that's one of its problems, is that anytime we do anything to the pancreas, there's the chance of leaking digestive enzymes and either defeating the stitches that we put in or causing injury to the surrounding tissues. The other job, of course, of the pancreas is to make hormones or things like insulin, much more benign, but important jobs just the same. But the other part about the pancreas, exactly why we have this love-hate relationship, maybe why we like to operate on it, is that it's a challenging part of the body to operate on. The pancreas, as you can see in this picture, is nicely all color-coded, is close to a lot of fragile structures. It's close to the main bile duct, shown in green here. And that's where all the bile that the liver makes passes through this little tiny tube, a liter a day. It's close to the portal vein in blue here, which is where all of the blood from our intestines, everything we eat that gets absorbed, has to go through the liver first. And that's the reason for that portal vein. But there's also a little red pipe here beside it. That's the superior mesenteric artery. And that supplies all of the blood supply to our small intestine, at least. And so very, very important artery, very, very important vein. And they're pretty much wrapped around by the pancreas. And then, of course, there's the stomach and the duodenum, lots and lots of structures there. So these are the two things that make the pancreas challenging to operate on and a real problem when we try to treat it. And again, making those digestive enzymes and just where it's located in the body, close to so many different fragile structures. And so when it comes time to thinking about things like ablation using heat or using freezing or injecting things, if this is the head part of the pancreas, we've just zoomed in a bit. Green is the bile ducts. This in pink here is the duodenum, that first part of the small intestine after the stomach. This is the big vein. This is the big artery that we just talked about. If there's a cancer right here, and you can tell the cancer because it's ugly looking. Cancers, they do look ugly. The rest of the human body is pretty beautiful. Cancers are just ugly. And if one was to apply heat to that or injection or freezing, that would be asking for trouble with how close that bile duct and that artery and vein and the duodenum are there. So if we were having this talk about 10 years ago, we'd be done right now. Nothing we could really offer in terms of ablation for pancreas, just because of all those anatomical things, all those considerations. There was a group in across the pond, let's say, that actually tried ablation with heat on the pancreas. It turned out terribly, again, for all the reasons that we would expect. They tried it, they had to try it. And then we realized after that we should never do that again. But thankfully, I remember sitting in our X-ray rounds, and every Thursday afternoon as a group, the 5 surgeons here in our program, along with our specialist radiologists, we meet up in a small conference room and we go over all of the scans together of the new referrals we have for pancreatic cancer and other cancers. And we really do depend on those X-ray docs to help us interpret these scans and plan for the surgeries we do. And I remember we were sitting in our little conference room. It's always dark in there. That's the way the X-ray docs like it. And one of our senior colleagues came into the room, Dr. Burscheid, and he was a guy, he's retired now. This was a few years ago now, but he's retired now. And every time he went to one of these conferences, he actually attended a lot of the conference, and he'd always come back with something really exciting to talk about. And this was no exception. He wanted to talk to us about something really cool that he had seen in San Francisco. I can think of a lot of neat things in San Francisco, but he said, came across something that I think you guys are going to want to hear about, something called electroporation. Okay, we were intrigued. He said it's a way of ablating things, and we said, oh man, okay, we're probably going to be heating things up, we're going to be burning things. Okay, doesn't sound that new. He said, yeah, no, this is something totally new, something totally different. There is no heat involved with this, and yet it kills cancer cells. Well, that had our attention a bit. He said there's no radiation involved. I mean, radiation's fairly safe. It's not without its problems. And I think the thing that really, really got our attention in the room was he said, you know what? This is really unique because it's different than anything I've ever seen before. This is safe for use in the pancreas. I went, whoa. That was a real eye-opener as soon as he said that. And at that point, we needed to know more about this, and we made it our goal to get this technology to our hospital at St. Paul's in Saskatoon. And within a couple of years, with the help of the foundations and that, we actually did get it there. And we've been using it at St. Paul's since 2015. Now, I'm going to be talking about this irreversible electroporation. I'm going to be saying IRE mostly. Of course, that refers to the nanoknife. That's the commercial name of the device. All three of these are exactly the same thing. So if I happen to say nanoknife sometimes, I'm still referring to the same thing. Probably the fastest terminology for me to use is just IRE, but I just want to establish up front that we're talking about the same thing here. And okay. So a good place to get started is how does this IRE work exactly? And that was definitely something that was on my mind the first time I heard about it 8 years ago. And I think maybe a good place to start out with is to talk about what IRE is not. And IRE, even though the commercial name is nanoknife, we're actually not cutting out the tumor at all. This is one of those situations where we are blasting the tumor, we are zapping the tumor, and the tumor, unfortunately, generally has to stay right where it is. So it doesn't involve cutting out the tumor, even though it's got that name of nanoknife. It's different than the gamma knife. We get a lot of referrals from across Canada, people asking if they can have gamma knife for their pancreatic cancer. Well, gamma knife is something totally different. It's quite useful in some brain tumors. It involves radiation, and nanoknife is something completely different. Doesn't involve any heat, doesn't involve burning, which is good because that's not what we want in the pancreas, given how close it is to all those structures. And I think there's a lot of patients who are hoping somehow this involves a laser. I'm sorry to disappoint them. It unfortunately doesn't involve lasers, although lasers are pretty cool. So this is my best depiction of what the nanoknife is. On the left side of your screen is the nanoknife device. And it looks a little bit like a portable ultrasound machine. Down at the bottom, I guess, is where the important stuff is. The top is essentially just a keyboard, and then there's a monitor to give us some feedback. What I've shown in the middle of the screen is a bunch of cells, and I've represented them by tennis balls, and you'll see why I use the ball analogy in a little bit. And these are the electrodes. Now, don't worry, they're just not that big. They're actually really quite fine. They're 19 gauge needles. That doesn't mean much to most people, but it's really about the same as the needles we use to draw blood when you have a blood sample taken. So there's nothing special about the needles that we use. They're fancy enough that we call them electrodes because they're going to be carrying an electrical current, and electrical current always goes from one point to another, or in this case, from one electrode to another. And so that base part of the machine, of the nanoknife, of the IRE machine, is really the part that will concentrate the electricity so that we can pass it from one electrode to another. And what happens is the machine's able to generate a very high current, very high, to the tune of 2000 volts per centimeter. Now, that didn't mean a lot to me the first time I heard about it, but I thought, you know, anything that's 1000 volts, that sounds like a lot of current. If you think about your dryer, you know, you plug in a dryer with the big plug. It's the one about the size of your hand. It's not just a little plug. That's about the 200 volt plug in there. Think of that multiplied by 10 roughly. It's high current. Thankfully, though, the machine is able to deliver it for a very, very short period of time. How short? Well, 70 millionths of a second. I don't know how it does that, but it does. And I guess I should be glad that it doesn't leave that current passing between the electrodes for 1 or 2 or 3 seconds, because I think then we'd generate heat and probably that would be trouble. But 70 millionths of a second seems to be just perfect to allow it to, we repeat that 90 to 100 times between all the pairs of electrodes. And after all that's done, what we have is this: the electrical current, that very high electrical current, even though it's very, very brief, will have the effect of punching holes in the walls of the cells that are in the treatment zone, that is, in between where those electrodes are placed. And these cells, well, I think somebody once said, it makes the cells be a little bit like sinking ships, you know, ships that have holes in the hull. So they'll start to take on water. They'll start to lose their content of proteins and electrolytes. And the cell will do its best. There's actually little pumps in the cell to try and get rid of the extra water, to try and bring back in the electrolytes. But eventually, it can only do that for so long. It'll run out of energy, just like somebody who's bailing a ship out. And eventually the cell will die. It takes, they say, about 4 hours after the treatment for the cell to die. And if we set up the electrodes like a box, like a frame around the tumor, shown here in yellow, and we set up these treatment pulses in between all the different pairs. Now you have to remember there's a lot of different pairs we can shoot the current between. That would be between 1 and 2, 1 and 3, 1 and 4, 2 and 3, 2 and 4, and 3 and 4. Then what we get is very nice coverage of the treatment. Nicely around the tumor, because that's the way we built the box, is around the tumor. In general, with any kind of cancer treatment, we don't just want to treat what we see. We always want to get a little bit more around there, 0.5 centimeter to 1 centimeter more. And you can see on the right-hand side of your screen that that's accomplished very well if we place those electrodes, those needles, just right. And I think my next question, and a lot of people's next question, is always, well, how is it that IRE with this super high current, how is it that it's really safe around bile ducts, around blood vessels, around bowel? Again, we could not apply heat close to these structures without injuring them. Why is it that we can do that with IRE? It's a very good question, and I really, really wanted to know myself. So again, it's extremely brief, but extremely high current that's passed right through the cells. The cells, if you remember high school biology, are made up of this sort of a fatty double layer of fats, of lipids. And the nature of the current is that it goes and it affects that lining there, just because there's a slight charge on the surface of the cell, very, very, very tiny. But that will have the result of poking holes in the walls of the cells. The good news, though, is that with such a short period of current, that current actually doesn't do anything at all to the proteins. Now, the proteins, that's the real structural part of the human body. The cells themselves, they're like jello. They're not all that strong, but the scaffolding, that protein in between the cells, that support structure that holds the cells in place so they can do their work, we're actually made up much more of the support structures. We're made up much more of proteins like collagen than we are of cells. And man, that was something that I did not know until I got involved with this nanoknife stuff. And just as an example, this is an artery where they've gotten rid of all the cells using chemical means, not using the nanoknife. And you can see it really still looks to me exactly the same as an artery that has all the cells in it. So in other words, we are much more made up of scaffolding, not so much made of cells. So if we go ahead and we blast holes into the cells and the cells die, well, you know what? The structure is still in place, so that the bowel is still strong, blood vessels are still strong and waterproof. You know, they've actually done studies where they've intentionally used the nanoknife on the bowel. And if you'd used heat there, well, within a couple of days, you'd have a big hole in the bowel. If you use nanoknife, the cells drop out, the structure is still strong, it's still waterproof, and eventually the healthy cells come and remake the lining there. So really kind of neat the way it does that. Not too surprising. It's not that it's really selecting the cancer cells, it's just that it's not affecting anything but the walls of the cells. And so that's why we can actually consider using IRE in these anatomically sensitive locations like the pancreas, close to that portal vein, the mesenteric artery, the bile duct, the pancreas duct, and the duodenum. All right, and I'd next like to we'll take us from start to finish of an actual patient. I mean, obviously without the name, without the actual pictures or anything like that, just to illustrate for you all the process of somebody who went through having an IRE procedure. But maybe at this point would be a good time if there's any questions before we jump into this. Okay, all right. We'll keep this pretty informal. If anybody has any burning questions as I'm talking, just feel free to to interrupt, not too formal here. And so I'm going to be telling you a true story. Again, enough of the details have been changed about this individual, but an actual story of about a 67-year-old male who was referred to our nanoknife program here in Saskatoon with a 5.8 centimeter mass in the head of his pancreas. And I'm not going to show too many scans, but toward the middle of the screen, outlined with a red circle, is about where the cancer is. And let's just say 5.8 centimeters is a pretty large pancreatic cancer. It's about the size of a pool ball, 5.8 centimeters. And you can see in a cartoon sort of on the right-hand side of the screen, that's about where it was there. Once it gets to be 5.8 centimeters, with all of the anatomy in there, it's not hard to imagine how that could be invading into nearby blood vessels, like that portal vein, that mesenteric artery, the bile duct for sure, the pancreatic duct for sure as well. And he undergoes a biopsy, and it confirms what everybody unfortunately thought was going to be the case, but he does have adenocarcinoma. He has pancreatic cancer. And thankfully, though, there was no obvious spread to the liver that they could see. And unfortunately, again, this has grown into so many of the vital structures here that based on the CAT scan, there was no surgeon anywhere who thought this would be removable with surgery. So it's unresectable, as we say. And so the next step, now that there's the diagnosis has been established with the biopsy, is that he started on chemotherapy. He started on FOLFIRINOX. It's a cocktail of several drugs, very, very strong. It's the latest and greatest, I guess, one of two of the latest and greatest chemotherapy regimens for pancreatic cancer. And what's really encouraging to me, I guess, as a pancreatic surgeon, is that 10 years ago, we didn't have any chemotherapy that was available that could really reliably shrink pancreatic cancers and bring patients to surgery who maybe were not eligible for surgery before. So he started on that with high hopes that hopefully we'll see him again and be able to offer him surgery. And he undergoes his chemotherapy for 3 months. And it's as anybody will say, it's no picnic. Those were his words. This was no picnic, but he got through it actually pretty good. He had really very little in the way of any missed treatments, and very little in the way of dose reductions or anything like that. Got through it as good as anybody can hope. And he actually, on the follow-up scan, had a very good response to chemotherapy. So the tumor now measures 2.8 centimeters in diameter. You compare that to the big pool ball sized cancer that he had there before. That's a tremendous response to the FOLFIRINOX, an absolutely great response. Again, they confirm that there's no spots on the liver, no obvious spread to the liver, and he's booked for surgery. I say, well, now it's moved away from some of those vital structures. Let's see if we can get this out. And this was actually in another province. He's booked for surgery. And unfortunately, in spite of their best efforts, still it was too stuck to branches of that main artery. Those are things that we can't sacrifice. We can't take them out. We can't get around them. And if we can't take out the whole tumor, we're not going to cut into the tumor and leave some of it behind. So they did the right thing. They backed out at that point. And at this point, the only option for this gentleman was to go for more chemotherapy. There's no getting this one out, unfortunately. And with the chemotherapy, he continues to have a very good response. Tumor is now down to 2.2 centimeters, about the size of a 25-cent piece. Big progress compared to how he presented initially. And the patient reads about nanoknife, about IRE, thanks to Dr. Google. Say what you will, it's good and it's bad. But reads about nanoknife, finds out that we're doing this kind of thing in Saskatoon. At the time, we were one of 2 programs in the country doing this. And he's able to get a referral from his oncologist to be assessed by us. And I think one of the first things we do, or any program does when they get a referral for a treatment, is we have to make sure that there isn't some reason that would contraindicate, that is, some reason that we're not able to do IRE in this gentleman. And so the commonest reasons are shown up on the screen here. One of them is if somebody has an irregular rapid heartbeat. It sounds like an interesting reason not to be able to do something, but there's a very good explanation. And that's because when we're delivering that high current through the machine, it has to synchronize to a part of the heartbeat where it's not likely to cause the heart to have an arrhythmia. That is, it's during a part of the heartbeat where it's not going to cause any troubles. Again, I don't know how it does that so quickly on the fly, from heartbeat to heartbeat, but if somebody's got an irregular heartbeat and it's ticking away at 125 beats per minute, there is just not enough time in between heartbeats to safely fire the machine. And on one occasion, we had somebody on the table, they were asleep. We tried, the machine just simply could not synchronize in a way that it would make it safe, and we had to abort that procedure. So obviously beforehand, if somebody has that problem, you need to see if it's a fixable problem, but if it's not, then unfortunately, the machine just won't work in those cases. Now, another important reason when we're dealing with this electrical current is if somebody has a metal implant within 10 centimeters of the treatment zone. And nowadays, there are all kinds of stents, essentially fancy metal tubes that are placed into blood vessels. And if that's fine, if it's down in the leg, that's far enough away, it's not going to cause any trouble. But if we have one of these tubes, one of these metal stents close by, or if there's a whole ton of surgical clips nearby, well, then something about the electrical current in that metal, they just don't get along. It's going to heat up. It's going to cause trouble with that metal implant. And we can't do it then. You'll notice the reason that I put here in red is probably the most important reason that we can't do nanoknife, can't do IRE, is the size. And we'll talk a little bit more about why that is, but it's pretty absolute. I think when this technology came out, south of the border, there were a lot of centers who were getting it. They thought it was useful for every tumor. They were trying it on tumors that were 5 centimeters with really pretty poor results. And I think we could say that over the last decade, the world has learned the hard way. We really, really have to stick to this size limitation. And we'll talk a little bit more about that on the next slide. Finally, of course, another important reason why we can't do IRE would be if somebody has metastatic pancreatic cancer. This is useful for treating pancreatic cancer or any kind of cancer if it's in one location. But obviously, if we just treat the pancreatic cancer and we have nothing to offer for spread, say, to the liver or to the lungs, then I don't know that we're necessarily helping anybody with that treatment. So it has to be localized in one location kind of cancer. And just before I forget, yeah, we've used IRE all over the body. Our program also treats kidney cancers, liver tumors, and some rare muscle cancers and those sorts of things. It can actually be used just about anywhere in the body. Now, I said the importance of size really matters when it comes to IRE, and the reasons that we stick to treating tumors under 3 centimeters in diameter is that the amount of mass, the amount of volume of tumor goes up very quickly as the diameter increases. So a 3 centimeter tumor, we really want the tumors to be 3 or 2 centimeters in diameter only. Well, there's about 14 cubic centimeters, 14 cc's, if you will, of cancer tissue. Pretty reasonable, 3 teaspoonfuls. Once you get up to 4 centimeters, doesn't sound like it's that different. Well, the volume is about 34 cc's, assuming a more or less round spherical tumor. And that's already more than double the volume. Once you get up to 5 centimeters, it's 65 cc's, and that's more than 4 times the original 3 centimeter tumor that we prefer to treat. And so once you get up to 5 centimeters, that's just a lot of tissue to be treating. And the next step, given that we haven't found any reason not to proceed with nanoknife, would be to bring his case to those rounds that we talked about. One of the topics we talk about is patients that have presented for possible nanoknife. And we discuss this with the radiologists, more importantly with our interventional radiologists. So those are the ones that can place the electrodes safely and around the tumor so that we can use the machine to treat the tumor. And we have to agree that this would be a good candidate. And it's mostly a consensus of several surgeons, several radiologists, sometimes some of the oncologists are present as well. And just 1 second here, checking on the chat questions here. Okay. Right. So yeah, I guess one of the questions had to do with if the tumor's in the pancreas but is now in the liver, can it still be done? And generally no, but I'll put a little, what's the term, asterisk here, because it's not an absolute thing. I think there's a big difference between somebody who has a pancreatic cancer and has, say, 10 spots of spread, 10 metastases to the liver. And that's quite different from the situation where somebody might have the pancreatic cancer and 1 spot in the liver or 2 spots in the liver. 3, I guess, depending on where they are, might be close enough. And I think there's more and more this sort of an extra classification for metastatic pancreatic cancer that we've been talking about around the world. And that's something called oligometastatic. Oligo, I guess, means very few metastases, because I guess potentially in those cases, maybe the behavior of those tumors is a bit better, say, than somebody who has 10 spots on the liver. And maybe there's some worth, especially in the case of just 1 spot, of burning that spot on the liver with something like a microwave ablation or nanoknife. It doesn't have to be the nanoknife, and treating the primary on the pancreas. I think when it comes to this disease, we have to keep our minds open to trying new things, to pushing the boundaries a little bit. So not completely out of the question, definitely a little bit controversial. Definitely there's a lot of doctors who would be dead set against that. But I think knowing what we know about pancreatic cancer, we have to keep an open mind and to try these things. Use multiple locations in one person. Yeah, I think that's more or less the same question. And Gary was asking about magnetic field. No, I'm not aware of there being any problem with using nanoknife and then subsequent MRIs. In fact, a lot of the time we use MRI to follow up on. So the electrodes, of course, we put in there for the treatment. As soon as we're done, the electrodes, they do come out right away. So that's not a problem. So getting back to our 67-year-old gentleman, he's found to be a good candidate. Everybody on the team agrees. The interventional radiologist thinks that he can get 4 electrodes nicely around the tumor, just going through the skin without us having to open him up, which is great. And patient agrees. He understands everything about the procedure. He's booked for IRE in the CT scanner for a couple of weeks down the road. And chemotherapy is stopped for a couple of weeks. Obviously, if we wanted to open somebody up and do surgery, we do have to have the chemotherapy off for 6 to 8 weeks, which always makes me nervous. Chemotherapy off for just a couple of weeks makes me a whole lot less nervous. And he's brought to the CT scanner in the X-ray department. It's not in the operating room. And even though it's done in the CAT scanner, even though it's done just through the skin, as they say, percutaneously, all of these cases do require a general anesthetic. So he's put right to sleep. It's actually a very deep anesthetic to any anesthetist I've ever talked to about this. And the reason is pretty clear, that when we're passing that current through the tissues of the body, even though it's a very, very brief current, it still can really activate the muscles nearby, those muscles in the back, those muscles in the abdominal wall. And so they really need a deep anesthetic so that the patient doesn't move around. And the anesthesiologists, I don't know how they do it. They do a great job. We've never had that be a problem. And this is Dr. Chris Wall. He's the real brains behind the whole nanoknife program. He's an interventional radiologist with just an absolutely amazing brain for planning how to put 4 electrodes in around a tumor without injuring anything in the process, and making sure that these are all parallel, that they're only a certain distance apart, not too far apart, not too close together, and so that we can get the ideal treatment for that particular tumor. And of course, putting needles in the pancreas is very nerve-wracking for anybody. There's a lot of potential for injuring things. So far, so good. Dr. Wall has managed not to injure anything inadvertently. There's always that possibility. Looking at the world experience, it's again something we don't hear about too much. He uses both ultrasound and the CAT scanner to guide those needles in. So he really can see where those needles are going to go and can really plan out in his mind how he's going to do that. So he starts out with ultrasound, and you know, when I look at an ultrasound, I got to say I don't see too much. To me, it looks a bit like one of those fuzzy satellite weather maps. So he's outlined for us where the tumor is here in red. And these are two of the electrodes here. He's kind of outlined in white lines there. And the idea is to get them surrounding that tumor. Of course, he'll put in two more in different planes here, but this just shows where two of them are and how close he wants to get to the tumor for good treatment. He wants to make it so that they're less than 2.5 centimeters apart. And this is one of the electrodes. It's really, again, not that big of a needle. It's a long needle to get to where it needs to be. You can see a little bit, there's an orange sheath, an orange covering, so that we can choose to only expose the active part at the tip for anything as small as 0.5 centimeter to 1 centimeter to 2 centimeters. For the pancreas, it's usually about 2 centimeters long there. And the rest of it is insulated. And once he's placed those 4 electrodes with ultrasound, this is where Dr. Wall's perfectionism comes into place. So we do a very quick, focused CAT scan of just that area. And he's able to look on the screen and see exactly where those electrodes are and really get a better 3-dimensional idea of what he'd have to do to get them just perfect. And this can reconstruct things and rotate them around, spin them around. He can see exactly where the tips of the needles are, exactly where they're running relative to the tumor. And he'll typically do 1, sometimes 2 rounds of adjustment of the electrodes, get some pictures. And once he's satisfied that everything looks perfect, that they're around the tumor, that they're not injuring anything, that they're all parallel and they're all equally deep, then he's ready to let the machine do its thing. And again, just like in that, I've shown this diagram before, we've got that nice frame around the tumor. Idea is to have the machine pass that high current, that very brief current between all the different pairs of electrodes and get that beautiful treatment zone around the tumor and then some, as they say. This is the part that's a bit time consuming. If you have 4 electrodes, well, there's 6 different pairs it has to fire between, 90 pulses each. Each pulse is timed to a certain part of the heart cycle. 540 pulses can take a while. So the time passes, but anesthesia watches the patient. We keep an eye on what the machine is feeding back to us, and we just let the machine do its thing. Once everything's all done, Dr. Wall does a quick check, a quick scan, making sure there's no problems in there. Usually the area that's been treated, he says, is kind of gassed out. It's clear that something has happened there, something bad has happened to the tumor, which is what we want. And he pulls out the electrodes. We put a little bit of pressure. We put just more or less something not much bigger than a Band-Aid over the 4 sites where the needles have gone in through the skin. And the patient is then allowed to awaken from that very deep anesthetic, spend some time in the recovery room. And to anybody who's had surgery before, it's one of the deepest anesthetics they've ever had. And again, we talked about why that is with the electrical current. A lot of patients without any prompting have said, wow, I feel weak as a kitten for the first 8 hours afterwards. And it's true, even holding up a cup of coffee can seem really heavy, surprisingly heavy, but it's just the nature of the anesthetic. And after those 8 hours, in the States, a lot of people go home the very same day. They're quite motivated to get out of hospital there for some reason. Here we do keep them overnight. And just another question came across the screen. What are some of the key risks? I.e. if someone has blood clots or is on blood thinners. And yeah, the key risks, I guess, for any ablation treatment has to do with not just injuring the tumor, but we always do worry about injuring the surrounding structures. And I remember the first few cases we did, Dr. Wall and I, we took everybody to the operating room. We wanted this done in an open situation where we can see what was going on. If there was going to be a problem, we wanted to nip it in the bud. And I got to say, the first time Dr. Wall put those 4 electrodes into the head part of the pancreas around the tumor, we both looked at each other and we said, my God, what are we doing? Nobody sticks needles into the pancreas. It was quite frightening, but the machine did its thing. Everything actually went very well with even that first case. and it showed itself to be as safe as everybody had talked about. But yeah, definitely anytime you're putting 4 needles, never mind just one, but 4 needles, 4 electrodes, there is a chance of injuring the stomach or putting a needle into a vein. And again, somebody like Dr. Wall, that should be extremely rare. He's very good. He's been doing this for 12 years, needles in. I think something that we were very afraid of was that by poking the pancreas, by doing something to the pancreas, what does the pancreas like to do to defend itself? Well, it sets up pancreatitis. Pancreatitis is nasty. Using the heat on the pancreas, in the past, said my internet connection's unstable. I don't know why. Anyway, definitely there was a lot of pancreatitis when they used heat. Nobody uses heat on the pancreas anymore. But yeah, in looking at our experience and looking at the group south of the border that's done probably 500 pancreas cancer cases with NanoKnife, the chance of pancreatitis is extremely low. We're very pleased with that. The guy in the States, out of those 500 cases, has had maybe 3 or 4 cases of pancreatitis, which is really good. That's less than 1%. Here we've had 1 case. We haven't done nearly quite so many as he has, but we're pretty happy to say that the chance of pancreatitis is not 0, but it is quite low. The chance of injuring a blood vessel or something, causing bleeding, again, in somebody like Dr. Wall's hands, the chances of that should be very low as well, in the order of a couple percent probably. So overall, we've been pretty pleased with the safety of all this, especially if we're able to do it through the skin without having to open somebody up. The expert in the States that I'm referring to is Dr. Robert Martin, and we went down to visit him in 2015, I guess, when we were looking to set up our program. Spent a couple days with the guy. The guy's amazing, very careful guy, very knowledgeable guy. He's always there to answer questions for us. I'm not sure when he sleeps, but yeah, he's the world authority, I think, on pancreatic NanoKnife, and just a solid guy. So yeah, our gentleman spends about three and a half hours in the procedure, spends a bit of time in the recovery room, and then goes back up to the regular ward. And we continue to keep people overnight in hospital. Again, in the States, different motivations. They try not to stay overnight if it's done just through the skin. Most patients will say they have minimal or no pain after this. Really, the sensitive part is the skin. The skin has the most nerves. The part on the inside, and we know this from years of doing heat ablations in the liver, same thing for NanoKnife ablations in the pancreas. It's really not something that the body perceives as painful. Another way to look at it, though, is that we're probably killing the little nerves that are around there. Same thing with the liver. When we're heating it, we were killing the nerves. And the liver and pancreas, strangely enough, are not that sensitive compared to the skin. So people will notice where the 4 poke holes were in their skin. They might notice a little bit of a bruise under there. But they say really overall minimal or no pain. It's kind of mind-boggling that we can do something to a pancreatic cancer and to even think about sending somebody home the very next day. It's amazing. And I love this Google clip art. People that always look so happy all the time, especially the healthcare worker. Not sure, but I'd be pretty happy to be able to get out of the hospital by the very next day. So that's by and large, most people are home the next day after this. And I usually follow up briefly a couple of weeks after, make sure everything's good. Generally is. Again, haven't run into too many problems with NanoKnife treatments. And after that, in the ideal world, and this is something we've really had to work with our oncologists on, is ideally, we feel a lot better if people can get back on their chemotherapy within a couple of weeks after their IRE treatment. And recently, most patients were able to get them back onto their chemo within a couple of weeks. And I think the idea there is very appealing to us. We don't know this for sure, but something appealing to me in giving it to this pancreatic cancer is the chemo there, we really wanted to finish off the cells at the edge of the treatment zone. So if we're looking on the right-hand side of the screen, the two little white dots, we're looking sort of perpendicular to where the electrodes are. These are two electrodes, let's say. And you can see the area, the size, shape of a peanut there is where you're really getting good treatment. It makes sense. That's where most of the current is zapping between those electrodes. You're going to get very good killing of the cancer there. And then there's going to be kind of this zone around that, just slightly around that, where we know that the current has done something. It's punched some holes in some of the cells there. Some of the cells are going to get sick. Some of them are going to die. They're not going to make it. Some of them, though, they're going to recover. And especially if there's any cancer cells in there, we don't want them to recover. And we know that the fact that they have a few holes in them, they're already kind of injured, they're wounded, it's not going to take much in terms of chemotherapy to help knock them off. So again, there's not a lot of scientific proof, not a lot of papers about this, but it's very appealing to us and the groups in Europe in particular, for some reason, to really get that chemo going again as soon as possible after, to just maximize that treatment zone, maximize that cancer cell killing effect. So to an oncologist, they're reluctant. I mean, definitely they're playing with some pretty strong drugs. And so they can be reluctant, definitely after surgery. This is a lot less than surgery. And with enough conversation and hand-holding, most of our oncologists are totally on board now. Let's get that chemo started within a couple of weeks. The follow-up, well, it's something that requires a lot of follow-up, and it's a little bit tricky. And we'll talk about some of the short-term and long-term effects here in a minute to answer your question. The follow-up imaging, we always get a scan at about 3 months. And I think Dr. Martin in Louisville, Kentucky, told us, don't jump in and scan too early because you may not know what you're looking at, eh? Remember all those cells in the treatment zone in the pancreas, they've gotten holes, they've taken on water, the cells are dead, and yet, you know, they're still there, they're still occupying space. So it can be humbling to look too early. And even at 3 months, when we look at the scan, the treatment zone is going to be kind of this blob of what looks like dead tissue, but we can't be sure. And really the goal of that 3 months is just to mostly look at the liver, make sure there's been no spread to the liver during that time. We'll have a quick glance at the treatment zone, make sure that we're happy with the way things look. Really the key follow-up scan is going to be at 6 months. It's going to be what's called a PET scan. We'll look at some pictures in a second. Follow-up in the first year, very intense, a CAT scan at 9 months, and then another PET scan at 12 months. And after that, probably down to every 6 months. After that, once a year. Pretty similar, I guess, to what a lot of the oncologists will do with any kind of treatment. Now, more about the PET scan. Again, I promised I'm not going to show too much in the way of scans. This is a PET scan here on the left-hand side of the screen, and I put a circle around the important part. A PET scan is really, I think if you could give it a better name, I'd just call it a cancer scan. It's going to light up in an adult those parts of the body that are really metabolically active. And in an adult, after we stop growing, there's not a lot that's that much metabolically active. The heart's always metabolically active. The brain is generally metabolically active. And it's going to light up those metabolically active areas, bright yellow, bright orange, bright colors. Now, I wouldn't pay too much attention to this over here and here. These are actually the kidneys. That's how the body gets rid of the tracer. So that's always going to light up. And then various parts of the intestine are always going to light up a little bit because they're always turning over. You know, it's like the lining of the bowel is a bit like a snake shedding its skin. We're always shedding the lining of our intestine and building new stuff. So there's always going to be some parts that are active. But this right here in the center of the screen with the blue circle, that's where this patient, that 67-year-old gentleman's patient, or where the tumor was. It's very bright, it's very active. There's no question that there's a cancer there. And at 6 months, this is the kind of scan we want to see on the right-hand side of the screen. Gone, we're seeing nothing. In fact, it looks like a black hole there. If anything, there's no metabolic activity going on there. It's beautiful. I mean, this is where we're really seeing that the treatment has worked. And this is just so gratifying to see this kind of a scan at 6 months. Again, pay no attention to the two other dots here. That's the kidneys. They're doing what kidneys do. They're getting rid of the tracer that we put in. But so beautiful to see that difference. between the pre-treatment and 6 months after the treatment. And so really that 6-month PET scan is the most important scan in our treatment. And the question about how many rounds of chemo before and after IRE, a good question. I think having chemo before IRE is something that over the last 3 years around the world, we've established as something that's pretty essential. I think in the years prior, it was a little bit experimental. We thought maybe the best thing to do is to get the IRE as soon as possible. Never mind the chemo, just go for it. But I think a real trend in all of cancer care is probably chemotherapy first and then something else, like chemotherapy and surgery. I think the days are coming when everybody with pancreatic cancer is going to have chemo before their surgery. Even if it looks like the tumor can come out with surgery from the beginning, I think the data is showing that the results are better if you have the chemo first, and even still better if you have the chemotherapy after. Again, the idea is to really give it to the cancer, get at any of the microscopic disease that might be left behind there, and that is translated to the best possible survival if people have the chemo before and after the surgery, before and after the IRE, before and after anything, that kind of thing. And the number of treatments, well, I think before IRE, we strongly suggest at least 3 months of chemotherapy, although definitely a lot of patients, like our gentleman that we're talking about here, I believe he probably had 9 months of chemo for different reasons, and that's fine too. And then afterwards, again, it's been a tough sell with the oncologists. You know, we're happy with even just 1 month, and it can just be a single drug. It doesn't have to be the full cocktail, but a lot of patients will just insist on, let's just give it right to the cancer. But even 1 month to accomplish our goal of getting that penumbra, that zone around the treatment zone as well as possible, I think would be accomplished with even just 1 month. So that answers the question. Chemotherapy definitely important to pancreatic cancer, period. And moving along then with our gentleman, obviously we're very happy to see at the 6-month mark that there's no metabolic activity where that tumor was treated there. And the results in our program and worldwide, I think we have to paraphrase this, talking a little bit about the different stages, and not to spend too much time. In Canada, unfortunately, when most people are diagnosed with pancreatic cancer, about half, if not a little bit more, the tumor's already spread outside of the pancreas. That is stage 4 pancreatic cancer. And really only about 15% of all the patients newly diagnosed in Canada will have a pancreatic cancer that can potentially be removed with surgery. That would be the early stages, stage 1 and 2. And that would involve really big surgery. I think a lot of people may have heard of the Whipple procedure. I don't like that name, but anyway, big surgery, all-day surgery to get that part of the body that's in the sensitive part of the body, making the reconnections to the pancreas, making the reconnection to the bile duct in the stomach. Big surgery, only about 10-15% of patients are candidates for that. And then there's kind of the in-between those two extremes. There's about 1/3 of patients where they'll have this locally advanced pancreatic cancer. So there's no spread to the liver, no spread to the lung, no spread anywhere outside of the pancreas. But, and it's a big but, that tumor has invaded blood vessels that can't be removed. And this is a lot like our gentleman whose case we discussed. It's growing into the vein, shown in the V here, the artery here. These are things that can in some cases be removed, not easily. I think the more there's problems with the artery, the more you can say that can't be removed. And so just like our gentleman, generally the only thing that can be offered is chemotherapy. And so far, this has been the main use of NanoKnife for pancreatic cancers, right? It's not an option when it comes to stage 4 because it's in more than one place. And most people, I think, if the best possible treatment comes from the big surgery, will opt for the surgery and not the NanoKnife. And this is that gentleman that we talked about, Dr. Martin, in Louisville, Kentucky. And this was his publication from 2015, around the time we were down there visiting him. He described at that time 200 open cases, and he still to this day does them all open. I think that's because he's not an interventional radiologist, but I think also the safety issue is high on his mind. And he documented pretty impressive survival for stage 3 pancreatic cancer, 18 months from the time of nanoknife from IRE, 23 months from the time of diagnosis. He was very liberal in assigning complications. That's just the way he is. He said 21% of his patients had complications. Now, some of these were pretty minor things, like skin infections, generally not life-threatening, a nuisance, but he reported absolutely every possible complication and found 21% of his patients had some. 2% of patients died within the first 90 days after IRE. It's an important marker. It's pretty reasonable given the seriousness of the disease. And University of Miami, a couple of years later, looked at 50 patients. They treated these like we do in the CAT scanner. So without having to open people up, they found an average survival of 27 months from the time of diagnosis, pretty similar to what he found, 14 months from the time of IRE, pretty similar, but without these people having to recover from having their abdomen opened up. And then overseas in London, England, the year after, a series of 75 patients, again, all with stage 3 pancreatic cancer. So really no other option for these patients other than just chemotherapy, no surgery possible. And he noted a single moderate complication out of those 75 patients. That was it. Found it to be pretty safe. And again, pretty similar statistics in terms of the long-term survival. And I think every time I've ever given a talk about nanoknife, the question is, yeah, but how does that compare to treating people with stage 3 pancreatic cancer who did not have IRE, who did not have the nanoknife? And so when we published our results, they're due to come out here very soon, what we did is we set up a comparison group with this SEER database. Now, without too much detail, that's a database, thousands and thousands of patients south of the border, so a little bit different population, not that much. And what we're able to do is with computer software, it's able to go in there and anonymously pick out 2 twins for each of our patients. That is, not exactly twins, but somebody with the same gender, with the same stage, with the same rough size of pancreatic cancer, and the same age. So really, it's like we have twins. The difference is, of course, none of those patients have had IRE. We compared that to our patients who had IRE for stage 3 pancreatic cancer, and we found our average survival was 27 months with IRE, very similar to what the larger centers have reported. And compare that to their twins, it was 14 months in those cases. So definitely there seems to be an advantage, seems to be some real benefit to using the nanoknife in these patients with stage 3 pancreatic cancer. But we were blessed in that our health region has been very supportive of our nanoknife program, and they've kind of opened the door and they said, it doesn't have to be just for stage 3 pancreatic cancer. They're very happy with the way we discuss everything as a group between several disciplines. And they said, look, if you find some cases and they've gone through your board and you think you want to use the nanoknife, you go ahead. And so definitely for stage 3 pancreatic cancer, that's the bulk of our cases. But here's another useful indication. In the cases of somebody who has had a Whipple procedure for a pancreatic cancer and the cancer comes back, if it comes back in just one place, well, we see that as a really good use for the nanoknife, because traditionally there's not too much you can offer these patients. It's terrible to reoperate. There's a chance to make things way worse. If you think of how everything's been reconstructed, this is kind of the nicest possible picture you could ever find. It's actually going to be surrounded with scar tissue. It's going to be surrounded by fatty tissue, and you always jeopardize the blood supply when you reoperate. And so if there was a recurrence, if the cancer happened to come back right there, traditionally there's nothing we could do. In fact, we didn't even follow patients that carefully, because even if we found something, what can we do about it? But to use the nanoknife to treat that has been quite safe. We've done it in a few patients, and we know that we've given these patients some useful time back. One patient, she's now about 4 years out from her recurrence after a Whipple's, treated with the nanoknife, is still around. We don't see any signs that it's come back yet. So pretty amazing. It's not a typical case, I'm sure. when a tumor comes back, that usually says something about its behavior. But it's encouraging that this is something that can be used, and it's changed the practice locally so that the follow-up after Whipple's, there's actually a lot more imaging going on so that we can find cases where the tumor comes back in just one place and be able to offer these people some added survival and some added treatment. A third use is for, I guess, what somebody once called the other cancer in the pancreas. So adenocarcinoma is the typical pancreatic cancer, and there's some rare subtypes, and that accounts for about 95% of all the cancers we find in the pancreas. There's another variant known as neuroendocrine, and if you remember, we talked about how the pancreas has two different functions. One of them is digestive enzymes, the other one is to make hormones. Well, this is more of a tumor of the hormone cells of the pancreas. And this is really a tumor that can arise anywhere in the body, anywhere that makes hormones, but the pancreas just happens to be one of those sites. And this is something that's less aggressive than pancreatic cancer, than the traditional pancreatic cancer, slower growing, it's more treatable, but it also has a higher chance of appearing elsewhere in the body years later. And to put somebody through a Whipple procedure for, say, a really tiny neuroendocrine tumor has always felt like a lot of surgery for a disease that should be more easy to treat than pancreatic adenocarcinoma. So definitely a lot of appeal here to treating a really small neuroendocrine tumor that would require a Whipple procedure, instead using the nanoknife electrodes. So we think that's a really good use. We've had a number of patients that we've treated that way. It works well so far. Somebody asking, are there some locations of pancreas cancer, head, body, tail, where IRE is not possible or less likely because the needles can't reach it safely? And that's a very good question. Our interventional radiologists, well, mostly Dr. Wall, who does this, says in most people that it's possible to somehow get those needles into the pancreas, whether it's the tail, whether it's the body or the neck of the pancreas or the head of the pancreas. And I think maybe the biggest limitation is, let's just say some people carry a little bit of extra weight, and then that distance between the skin and where the pancreas is, because the pancreas is right at the back, it may be beyond reach of the needles. So that's one of those instances where it just may not work, in which case we may need to think about having to open somebody up to get those needles into position. But I think by and large, to the whizzes in interventional radiology, there's not much that can't be reached with a needle. So again, getting to other possible uses, patients with pancreatic cancer who are not medically able to have surgery is another group. And in fact, in our group, we've come across 6 such patients over the last few years. And let's just say they had a small tumor. It was only in the pancreas, and but they simply just had too many medical problems to even think about operating on their pancreas. And they understood that this was a fairly new technique, and they agreed to go ahead with this. They were actually all unwell and unfit, I guess is the term, not medically able to undergo any chemotherapy either. So this was the only treatment they had. And we just curious to see what would happen. And the average, sort of the median survival was 15 months, not bad. Better than the average of somebody who has absolutely no treatment for pancreatic cancer. And one patient, there's always that one that's the outlier. One patient is surviving to this day with no signs of recurrence at over 3 years since his nanoknife treatment. And that's pretty amazing considering he never had any chemotherapy. And that begs the question, could this also someday be an option for those really fit, healthy patients who simply don't want to have a Whipple's? We've had people who have asked that question. You know, I can't say that that I wouldn't think of that myself if I had a small tumor in my pancreas to go for the nanoknife instead of the Whipple. And, you know, I do Whipples for a living. So it's something that needs to be thought about. And I see it as a potential use in the future for this technology. All right, I think probably running a little bit long here. Do we need to wrap it up here? I just got a few minutes left to talk about the future of IRE, but much probably might be more useful to take live questions, but I can go whichever way you like.
Completely up to you. If you'd like to finish your presentation, we're in no rush.
Okay.
But
I'm surprised I've gone over. Normally it's a pretty solid 45 minutes, but we're clearly over an hour now. So anyway, well, the future of IRE is interesting. Just a question about genetic mutations and acinar cell. And yeah, I think to answer both questions about, you know, what caused the pancreatic cancer in the first place and the various subtypes, I think that's the neat thing about IRE, is that it can be used to kill any kind of cell in the body. So again, I think it's been used in lung cancers, breast cancers, a lot of interest now in prostate cancer. And so the type of cell doesn't matter so much. I think the most appealing thing about IRE is that we can safely use it in the pancreas and not put the portal vein at risk, the bile duct, the nearby bowel at risk. So I think there's no particular added challenge. Again, as long as Dr. Wall or somebody like him can put those electrodes nicely around the tumor without injuring anything, the technology works well on all cell types. So the future of IRE, well, I remember giving a talk a number of years ago when we were trying to make the push to get NanoKnife to our hospital. And I gave a grand rounds one day, and after the talk, this was a long time before COVID, this gentleman, Dr. Jim Zhang, came up to talk to me, and he was pretty excited. And he's one of our local immune cancer experts, but apparently quite world renowned. He's got probably 500 publications, and he was quite excited by what I talked about. And I was puzzled by this because I'd never heard of the immune system mentioned in the same breath. I was pretty happy that this was something we could actually safely use in the pancreas. And he said, you know what, Mike, when you guys do those treatments of liver cancers and you're burning them with microwave ablation or with radiofrequency ablation, well, you're completely destroying the tumor cells, you're burning the proteins on the surface. There's nothing recognizable there. And I went, yeah, true enough, that's true. But in the case of NanoKnife, well, there's no heat involved. And you're killing the cells by blasting holes in the fatty envelope, but the proteins are completely intact. The proteins are completely left alone. He said, this fascinates me. And I was like, okay, keep talking. And he said, you know what, the fact that the cell is no longer able to defend itself and that those proteins are still there to be recognized by the immune system, well, what you have there is like an old-fashioned vaccine. Now, vaccines these days are quite a bit different, but the very first vaccines they did by injecting killed bacteria cells, say, from, you know, if they were vaccinating against a bacteria. And the bacteria obviously couldn't make somebody sick, but the proteins were there to be recognized by the immune system so that the immune system could build up reserves. So the next time it actually saw a live bacteria, it would be able to kill it. Well, he said, guess what? I have a feeling it's the very same thing when it comes to dead cancer cells. Okay. He took that to the lab and found that, yeah, actually using IRE and cells in a petri dish and different other models, that, yeah, there was a certain amount of immune response against dead cancer cells that was possible. And what was even more exciting is he decided to combine it with some of these immune boosting drugs. And that's a big deal, I guess, for some liver cancers, for some lung cancers. So far, not all that much impact for pancreatic cancer, but I think that day's coming. And these immune boosting drugs, well, they do that very well. They can boost the immune response against cancer cells. IRE boosts the response as well a little bit, but man, he said, you know what, Mike, when they put those together, and it took a few years of research to come to this point, he said, this is crazy. It actually would set up the immune system to attack cancer cells of that type anywhere in the body. And they did a model where they set up a tumor in 2 places in the body. They zapped one of them with IRE, they gave the immune boosting drugs, and guess what? That second tumor that was there that wasn't even zapped actually started to shrink. So I find this to be amazing, incredibly exciting. especially for people who have metastatic disease. And this is just some of the papers. There's way too much detail in these slides, but the key thing here is that in this mouse model at another center overseas, that the immune response to pancreatic cancer in particular was boosted when you combined IRE and an immune boosting drug. And then again, this is Dr. Martin's group doing some great work in Louisville. They actually did this in humans for the first time, combining their IRE treatments with the immune boosting drugs. And again, it's a phase 1b trial. It's essentially to see, is this safe? You know, is this a safe combination? Seems to be safe. They're moving on now to a phase 2 trial, and hopefully we're going to see some exciting results coming from that in the near future. So again, the idea in the future, maybe it's possible to treat one metastasis in the liver, give these immune boosting drugs, and then have the immune system turn against cancer cells of that type anywhere in the body. To me, that's incredibly exciting. So we'll have to see what comes out of that in the near future. Just to wrap it up, the take-home points here. Well, IRE, I think it's pretty safe to say, in spite of Dr. Wall and my initial reluctance to put needles into the pancreas, it really has turned out to be a really safe ablation technology. The most common limitation comes down to the size of the tumor and to who we can offer this to and who we can't. We want that tumor to be as small as possible, ideally under 3 centimeters, under 3.2 centimeters as an absolute cutoff. The IRE results for stage 3 pancreatic cancer, where most of these treatments have been done, is encouraging. It's almost a doubling of the survival of what's really bad disease. And IRE can also be used, though, for other cancers, that neuroendocrine pancreatic cancer, recurrent cancer after Whipple procedure in particular, and for patients not able to tolerate major surgery. And again, we just touched upon how exciting it is that maybe combination of IRE with immune boosting drugs may be a great way to treat cancer that's gone outside of the pancreas. So with that, finally, I guess if anybody's interested in accessing IRE, this is not an advertisement or anything like that, but just to know that there's 2 centers in the country that do it right now for pancreas. There's a couple of other programs coming soon. But so far it's us. We're always happy to look at scans from out of province patients. We don't charge a fee or anything like that. We're still learning. I mean, we're still, even though we've been doing this for 7 years, we're still learning from each and every case. When it comes to the actual treatment, it's of course covered if you're from Saskatchewan. 3 other provinces, family members have gone to their provincial healthcare programs and established coverage there. Not all provinces so far cover the procedure yet. But if there's any questions, my email address is pretty straightforward. We're pretty open to doing anything and everything we can to fight this disease. So with that, I'll be happy to take any questions if there's any time left. That's a good question. I hadn't thought about it that way before, but yeah, I don't think there's any risk to spreading the tumor when we're doing the IRE, because of course we're not actually entering into the tumor. So we're going around the tumor, and you're absolutely right. It's just because of the behavior of pancreatic cancer. We just want to see for sure that it hasn't gone to the liver. That's obviously going to change things in terms of the prognosis. It's good, useful information to have. And that's the main reason that we do that 3-month CT scan. Well, yeah, definitely. I mean, I think we're in a process of having to change people's minds here, and I think definitely what you describe is that classic oligometastatic scenario. And I think given how, it's sad but true, as treaters of pancreatic cancer, we're quite defeatist. People are quick to give up, quick to say, there's nothing else we can do here. But what you described to me, to a lot of surgeons nowadays, sounds like an ideal situation to say, well, hey, it's one spot, it's oligometastatic. How long has it been since your pancreatic cancer your primary was removed? Just see, that's another good sign. There's a fair interval of time, and you still got just the one spot there. Now, I think there's very little about the liver that the interventional radiologist can't get to with a needle to burn with a microwave ablation or a nanoknife. I think to go in and plan a major liver surgery, well, yeah, I can see why people would be more reluctant with that, because the teaching in the past has always been, if you have one metastasis, you may well have 5 metastases. You've had the test of time. It's always been in that one place. To me, something very reasonable would be to think about having microwave or nanoknife to that spot, assuming it's small enough. Surgery does seem a little bit aggressive, but if it was off in a more accessible part, why not? We want to throw everything we possibly can at this disease, and that does not sound unreasonable at all to me. In fact, that's something in our program we'd probably be pretty aggressively pursuing.
Great. Well, thank you so much for this great presentation. If anybody has any further questions, you can send us an email. And thank you again. Is there anybody else or anything else you'd like to add?
No, thank you very much for having me. I love talking about this topic, and yeah, I'd be happy to take any questions that people think about after the fact. Absolutely.